Thank you very much for such a kind introduction. And also thank you very much for the honor of inviting me all the way from Toronto to come and present here in beautiful Mexico City. It's my first time in the city here. I'm really enjoying my visit, and it's, can we go back a slide? Sorry. It's my first time here. I'm really enjoying the visit, and I've also been very much enjoying all of the presentations from the speakers in so many diverse areas of research. It's an exciting time to be in psychiatry today. It's exciting in the same way that it was exciting to be in pharmacology in the years 1950 or years 1960, 50 years ago, the period which we called the golden age of psychopharmacology. I think when we look back upon this time, we will think of this time as the golden age of brain stimulation. Things in brain stimulation are moving so fast, so much progress in improving the quality of the treatments, the speed of the treatments, the effectiveness of the treatments, and the many different diseases which we can treat using brain stimulation. I don't have a slide advancer here, so can we go to the next slide then? Oh, back one. There we go. But before we discuss progress, it's important to ask, progress against what? What is the problem for which we are trying to make progress? And the problem is that even with the best of our therapies, and even with the best of our medications, many, many patients still have depression, and many, many patients still die by suicide every year. We have worked very hard for the last 30 years to improve the number of people who receive medication, the number of people who receive effective therapy. And yet, in the United States, no change in the prevalence of depression, no change in the prevalence of suicide. In Canada, it is the same story, and I believe in most countries in the world. We still have not made very much progress to improve the number of people who have depression. Compare this to smallpox, a disease for which the prevalence has gone to 0. Compare this to polio, a disease for which the prevalence has come down very low. It is possible in medicine to make tremendous progress very quickly in other areas of health. Our goal should be to make the same rapid progress here in psychiatry. To do that, we will need more than prediction. We will need more than personalized medicine. We need new tools. We need new treatments. We need better treatments. So let's look at the progress we're making, because I believe that in 20 years, when we look back at the number, we will see that there will be a meaningful reduction in the number of people who have depression. And we will be able to point to that and say that reduction in depression has come in large part from brain stimulation. If we succeed, then we have made progress. So here's transcranial magnetic stimulation, already discussed by many of the speakers today. Very nice. We cannot call transcranial magnetic stimulation a new treatment anymore. It's not a new treatment. It's a bit too old. It's middle-aged. It's 33 years old. And I'm going to try to give you a timeline of its life, maybe like a timeline on Facebook or something. So we can see there is transcranial magnetic stimulation. In the background is its partner. Its partner is brain imaging. And brain imaging and rTMS have worked together, but sometimes effectively, sometimes not effectively. So what is its relationship status? We'll say, oh, it's complicated. Okay. Here is the baby picture. The baby picture of rTMS. 1985, you can see a magnetic coil for the first time capable of stimulating the brain without surgery, non-invasively. This is very important. We have developed some very exciting treatments with deep brain stimulation, stimulating the brain with neurosurgery. But it will be very hard to do neurosurgery for 2% of the population, or 5% of the population. Non-invasive is critical. If we can stimulate the brain without surgery, we have a chance to make this treatment a solution for many people. rTMS by age 10 was already showing some promise as a good student. It was maybe a prodigy, like a child prodigy. This is the first time by age 10 that they're showing that when rTMS is delivered to the dorsolateral prefrontal cortex, that there are strong effects to treat depression. Now, for those of us who are parents, when we have small children and the children do well in school, we place very high expectations on the children to perform. Here we go. These parents say rTMS might obtain results similar to ECT, but without requiring the epileptic seizures. So this is a very high expectation. And as usual, when we place high expectations on our children, sometimes they do not meet the expectations. So in the next 10 years, it had a troubled adolescence. rTMS was working better than placebo against depression, but never as well as ECT. At this time, many of the investigators and the parents became disappointed in their child. And they said, well, maybe this child is not going to perform as well as we thought. In fact, maybe it's not good for anything. But as with many adolescents, many young people, rTMS is going through a crisis of identity, asking questions about itself. How many pulses should I have? How many sessions should I have? Where should I be on the brain? What pattern of stimulation should I be? And so it is seeking its identity, and perhaps for this reason, it's not performing as well as we expected. However, some exciting things did happen. By age 19, rTMS develops a very interesting skill. In the past, to use rTMS to induce plasticity, neuroplasticity in the brain, you needed many sessions, 3,000 pulses, maybe 20 minutes, 30 minutes, 60 minutes. Theta burst stimulation with only 600 pulses and only 3 minutes. And yet, with 3 minutes, you can induce the same plasticity in the motor cortex as you would require before 30 minutes or 40 minutes or 60 minutes. So this is 10 times faster delivery of the stimulation. And yet, more powerful on plasticity, more plasticity. So this is important. We need to remember this. This will come back. Meanwhile, by age 23, rTMS finally becomes an adult and gets its first real job. FDA approves rTMS in major depression after a study, 325 patients. You can see in the depression scores, the active rTMS had better improvement than the placebo rTMS. And after this, FDA gave approval for rTMS treatments. In Canada, we have approval, and in many other countries here in Mexico, there is approval in the European Union. So many countries gave approval. But it was, in some ways, not growing very quickly. Because, for one thing, you need a lot of sessions. This is a study of a replication of efficacy. A second study in another 190 patients, again, shows active stimulation better than sham. So this was a confirmation that rTMS was useful in depression. But I will show you a picture. Can you see the improvement in the depression scores was taking as many as 10 or 12 weeks for maximum effect. So that's a lot of sessions. Patients have to come in Monday, Tuesday, Wednesday, Thursday, Friday, 5 days a week for 12 weeks, 10 weeks. This is a very demanding treatment for the patients. And unless we improve something, this is going to be a big problem for treatment. This will be very hard for everyone in the world, for most people to relieve. So if this is rTMS, then rTMS is not the solution yet. We need more work. What do we need to work on? Well, from age 25, this is around the time that I established my clinic in Toronto. rTMS was about 25 years old. And this is around the time when things started to get interesting. When I started the rTMS clinic, my colleagues, they were surprised that I would do this. They said, oh, we know rTMS. rTMS, it's like ECT, except it doesn't work. So they say, why are you studying rTMS? I said, I think we can improve it. What do we need to improve? Number one, capacity. If a treatment session is 1 hour, we can only treat a few people every day, 6 or 7 people every day. And if they need 12 weeks of treatment, your whole clinic will be only 40 or 50 people. That's not enough. We will never be able to solve the problem. But if the sessions are fast, if the sessions are 3 or 4 minutes, then we can have many people coming every day. In my clinic now, every one of my machines has capacity for 20, 25 people every day. We have 10 machines, so we could have, right now, we have every day more than 100 patients come for rTMS. We have room for 200. So this is important. Number 2 is cost. In United States, that's 200 United States dollars per session. This could be $10,000 for one course of treatment. In Canada and Europe, almost the same. The good news is we can fix this. If the sessions are shorter, then they can also be costing less. If the sessions are 10 times faster, they can also be much less expensive. So this is helpful. Number 3 problem, the patients have to come in every day for the treatment. In Toronto, this is a problem. And in Mexico City, the traffic is even worse than Toronto. I didn't think it was possible, but it's... So this is a problem. We need to fix this. Patients cannot come 30 times or 50 times. They need to come only a few times. So we have big things to fix. If we can fix these problems, rTMS goes from being not a solution to maybe a solution. Okay, number 1. Let's try to improve capacity and costs by 3 times, by 10 times, as many times as possible. How will we do this? We will try theta burst stimulation, 3-minute treatments. Now, already 5 or 6 years ago, we knew that theta burst stimulation had more power than sham stimulation. So we already know theta burst is better than sham. That's not the question. The question, is theta burst better than standard, conventional treatment? To study this question, we got a lot of Canadians together. Canadians from Toronto, Canadians from Vancouver, 3 major hospitals. CAMH is like, it's a bit like this Instituto in my country. University Health Network, that's my hospital. It's a big hospital, general hospital. And University of British Columbia. We all had rTMS treatment clinics, and we came up with theta burst versus high frequency rTMS effectiveness evaluation in depression, or 3D. The trial took 6 years. It took 6.5 years to think of the name. So here's the idea. 414 patients with major depression. Half of them will get conventional, standard treatment. 38 minutes every day, 20 or 30 days, 3,000 pulses. This is the FDA standard treatment from 10 years ago. The other half, we just change the settings on the machine. Same machine, but only 3 minutes. We mimic the theta burst patterns of the brain, and we do theta burst stimulation. Randomly, so this is a randomized trial. Half will get one, half get the other. Immediately you can see this trial has some problems. Number one, patients are smart, and they can tell if they are in the chair for 3 minutes or 38 minutes. And sometimes they complain that they only get 3 minutes. No, I want 38 minutes. Why do I only have 3 minutes? I had my car, it took 2 hours in traffic to come in. And now it's only 3 minutes, and now 2 hours back again. So we were worried that the 3-minute treatments would be impaired. Right. But we had blinded raters to rate the depression symptoms, Hamilton Depression Rating Scale. And we took the two collections of numbers, we didn't analyze them, we gave them to a third statistician, and we said this is group A and this is group B, we're not telling you which is which, so we would not be tempted to cheat on the statistics. And when we plotted the graph of the trajectories of improvement for group A and group B, it didn't matter because they were right on top of each other. So this was a paper published last year in Lancet, 3D. The 3-minute treatments in blue, 38-minute treatments in red, and statistically within 1 point on the Hamilton score. So very high confidence that the 3-minute treatments, we were hoping they would be superior, not superior, but not inferior to 38-minute treatments. Okay, so this was exciting. We were happy about that. Our patients were happy. Our waiting list for treatment, patients used to have to wait 6, well, sometimes 3 or 4 months to come in for treatment. After 3-minute treatments, now they're coming in 1 or 2 weeks, so nobody has to wait. This was good. But the patients are still not happy. They said, well, wait a second. I still have to drive to the hospital in traffic 30 times, 6 weeks. It's a lot of work. And even if the treatment is free, we charge $0 for our patients. It's a charity, so nobody in our clinic has to pay for the treatment. But they do have to pay for the parking. And they do have to pay for the gasoline and the car and the transit, so it's still very expensive. And if you are an inpatient, 30 days of treatment is too much, right? So we're still not there yet. The patients ask an interesting question. Some of the patients said, well, can I have 2 treatments today or 3 treatments today? Could I have more treatments every day? So we thought this would be an important question. In fact, age 25, 10 years ago, Paul Holzheimer in United States did accelerated rTMS. Day 1, 10 sessions every hour, 9 o'clock, 10 o'clock, 11 o'clock, 12 o'clock, 10 sessions. Day 2, 5 sessions. So 15 sessions in 2 days. And 1 out of 3 patients, remission. And 6 weeks later, still in remission. So this was interesting. A few years later, in Belgium, my friend Chris Bakken, 5 sessions per day, 4 days, 20 sessions in just 4 days. And again, many patients responding to treatment, many patients going to remission. Not all of them, but some patients go into remission in 4 or 5 days, and remission is continuing for weeks. What about comparing to standard treatment? So here is Paul Fitzgerald, Australia. Half of the patients come every day, 1 session per day, 5 days per week. The other half come 3 sessions per day, 1 hour apart, 9 o'clock, 10 o'clock, 11 o'clock. Only Monday, Wednesday, and Friday. The next day, Tuesday and Thursday, the next day, Wednesday. So 6 days only. 6 days or 20 days. Outcomes appear the same. So again, similar ones. So many sessions per day seem to be helpful. The most ambitious, the most aggressive is in California. In California, my friend Nolan Williams proposed a new approach. 10 sessions per day for 5 days. 50 sessions. So 1 session every hour, theta burst stimulation every hour. What was interesting was remission happened usually in 3 or 4 days. Most patients already in remission by 3 or 4 days. But the success rates, percentage of remission, did not go down. It went up. When you do more sessions per day, he is reporting minimum 85% of patients in remission. Everybody thinks this is crazy, right? There's nothing that does 85% remission in depression. But he has been seeing this. In the last 3 months in my clinic, we have begun the same approach. It seems to be working. My colleagues, Center for Addiction and Mental Health, they have also seen some success. And my colleagues in the United States, in Texas, also are seeing some good results. What is interesting is that some of these patients are very difficult cases of depression. Some of these patients already tried rTMS, no effect. Some of these patients already tried ECT, no effect. But they are going to remission with rTMS if the rTMS is 10 times per day. When you examine those patients, you see their problem. When you treat them, they go to remission, but they lose the effect 10 or 20% every week, so very fast relapse. This is important. What it means is the patients we are calling non-responders, they may not be non-responders. They may just be very fast relapse patients. 1 session per day is not enough to make progress. 1 session per day is enough to keep them well. 10 sessions per day, they will improve. After that, they need to do a session almost every day, and they will maintain the effect. Now, for rTMS, it is crazy to do rTMS every day for the rest of your life. But for medication, it's not crazy. For medication, it's very simple to take rTMS for the rest of your life. So we need to find a way for patients to get rTMS every day if they need it. If this happens, I think we will get a lot of patients to remission in 4 or 5 days. And I think some of those patients will even be patients who do not respond to ECT or medications or rTMS or anything. The trick is to reset the circuit faster than it can come undone. ECT only 3 times a week, usually 2 or 3 times a week. So in those 2 or 3 times a week, that's 48 hours for the brain to go back into its former pattern. This is not as strong as ECT, but it's very often. The brain has no opportunity to go back, to regress into its previous pattern of activity. And it's very simple. There is no artificial intelligence. There is no machine learning. There is no prediction. This is dosing. It sounds crazy, but remember, when rTMS was invented, no one ever did dose response. it's 1 time per day as the conventional, not because we decided this is the best, but because 20 years ago, someone did once per day, it worked, so now everyone does once a day. Did anybody check 2 times a day, 4 times a day, 8 times a day? No, until now, no. So you can make big mistakes if nobody does dose response. And you can make big mistakes if you just copy the study of the previous researcher. But this is what happens in medicine sometimes. We try something, it works, so everyone does the same thing. 50 years later, we assume we do it this way because everything else has been checked and this is the best. Sometimes no. Sometimes it's just one thing that worked. So it's important to test other ideas. And all of this is a simple hypothesis. rTMS is underdosed on 1 time per day. And if it's underdosed on 1 time per day, then this is very interesting. 10 times per day rTMS means the whole treatment is only 5 days. This means you can use it in the hospital, on the inpatient unit, in the emergency room. It also means you don't have to drive to hospital in traffic 30 times. Just lots of sessions. This could be one of the biggest breakthroughs we have seen in 20 years. At the moment, our group of 3 hospitals is going to do a study in 200 patients to confirm or to see if this is true or not true. Okay? All right. Now, everybody loves personalized medicine, so let's talk about personalized medicine. Can we improve rTMS remission rates with personalized medicine? Some patients do not respond to rTMS. If they don't respond, maybe it's because the dose is too low. Or maybe their depression is a different depression from the depression of the other patients. So personalized medicine means a method, a reliable method, to identify the type of depression with some kind of test. So far, the best one we have been able to come up with, the best one we have is functional MRI. This is a study from Drysdale and colleagues, lab of my friend Connor Liston. He obtained 1,200 scans from patients with depression. And he organized the scans to check for every patient 258 regions of the brain to look at the correlation of activity between them. Every one of those squares is a correlation grid of every area connecting to every other area. So for every patient, you have a signature, a biotype of that patient, a map of every area and its connections to every other area functionally on brain activity. So maybe they all look the same, but they don't. With those 1,200 scans, he applies machine learning and discovered 4 different types. So 1,200 people meet criteria for depression, but there are these 4 types here. And each one has different symptoms. They're all depressed, but one of the types has high anxiety and anhedonia. The other type has high anxiety, no anhedonia. The other type has high anhedonia, no anxiety. And the final type has depression, but no anxiety and no anhedonia. Each one has its own signature, biotype on the scan. He tried to send this paper to the journal Nature Medicine, but they said this isn't medicine, this is just mapping. It's not medicine unless you can use these types to plan a treatment. So he called me and he asked for my scans. So I gave him my scans from my patients for rTMS. And he checked them, and from my patients, some of them were type 1, some were type 2, some were type 3, some were type 4. And then I told him which ones respond to rTMS, which ones don't respond to rTMS. This was very exciting. This is the response rate. Type 1 and type 3, 60 to 80% respond to rTMS. Type 2 and 4, not a good outcome. Only 20 or 30% are responding to rTMS. So they're not all the same. And you won't get all of the patients just with more dosing. You won't get all the patients just with more sessions. Overall, the response rate is only maybe 35% remission. But what this tells us is that the low response rate for rTMS is partly because we have a mix of patients. If you pick your patients, you can have a high success rate. But the ones who don't respond, the rTMS is stimulating the brain, but it's the wrong circuit. It's not the circuit which is driving their depression. Not every patient has a circuit, not every patient has depression which is created by the same circuit. So, what do we do with these guys? What do we do with them? These people here. Well, we can look at the scan of these people and see what looks different. What looks different is that the focus of abnormal activity was not in the area of the cortex where we stimulated. With rTMS, we stimulate in the dorsolateral prefrontal cortex. These patients did not have a problem in the dorsolateral prefrontal cortex. These patients had a problem in the right lateral orbitofrontal cortex. Now, this is very exciting because 10 years ago, we didn't know as much about this region, a bit mysterious. But now, in the last 5 years, we have learned a lot about the right lateral orbitofrontal cortex, and it seems to be the opposite of the circuit of reward, the circuit of pleasure. The brain also has a non-reward circuit, and it's not in the ventral striatum and frontal pole, it's over on the side. The non-reward circuit is in this area here. There it is. Yeah, so there's a whole network of areas which are responsible for negative incentives, for negative motivations. Not obtaining reward, but avoiding punishment, avoiding difficulties. And these areas of the brain are critical for the non-reward. So what are we saying? That some patients, that non-reward circuit is the focus of the entire activity of the brain. They've gotten stuck. It's not that their reward circuit won't turn on. The problem is that their non-reward circuit won't turn off. This is interesting because this is exactly what the patients describe. When I tell the patients when they have depression, if you tell them it's a chemical imbalance of serotonin in the brain, but if you tell them your brain has a non-reward circuit for identifying problems in life, negative consequences, and trying to avoid them, and yours has got stuck in a loop and going around and around in a circle, and the patient says, yes, this is exactly what my life is like. This is exactly what my life is like. I want to think about other things, but the only thing my brain wants to think about is the negative sides of life. I have no motivation to do anything because all of my motivation is to avoid the world and go home, to avoid the world and hide. Right? The non-reward circuit is driving it. Right? Well, what if we change the target of rTMS? What if we aim the rTMS at orbitofrontal cortex instead of dorsolateral prefrontal cortex? Is this a crazy idea? Well, maybe not. Last year, a team of neurosurgeons in San Francisco studied a group of patients with epilepsy. These patients with epilepsy were preparing to have a surgery to remove the focus of this epilepsy from the brain. And because of this, they had electrodes all over their brains. This is in an epilepsy monitoring unit, so they're waiting for about 7 days. 7 days in hospital. Electrodes everywhere. And they're waiting for a seizure, and waiting and waiting and waiting. But while they are waiting, you can check for other things. And what they noticed was some of the patients, can you see over here on the right? Some of the patients who had depression, and some did not. And if you check their mood during the day, you can give them a small tablet. It was a 3-minute questionnaire. Positive thoughts and negative thoughts. And as with all people, sometimes the negative thoughts are very strong, sometimes the negative thoughts are not so strong. So all through the day, more negative thoughts, less negative thoughts, and so on. So they checked the negative thoughts against the activity of the brain on all of these electrodes. And they found a pattern. Whenever the negative mood content was strong, there was a lot of theta power and a lot of alpha power, specifically in the lateral orbitofrontal cortex. Other areas of the brain, not so much. But alpha and theta in the lateral orbitofrontal cortex, you can see the points are red, the red points on the brain. These are the areas where you could predict the mood from the alpha and the theta power. So that was interesting. But only half interesting, because it's still only a correlation. Correlation is not the same as causation. We need better evidence. Electrodes can go both ways. You can record, but you can also stimulate. So they apply 100 hertz stimulation to electrodes all over the brain. They don't tell the patient which electrode, and the patient cannot feel the electrode. So they stimulate here, 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 and they say, tell us your mood, and tell us your mood, and tell us your mood. Whenever they stimulated the orbitofrontal cortex, the negative mood thought content, the negative mood went down. Positive content did not go up. That was important. It was only negative mood going down. And you could see that there was a reduction in the theta and the alpha power. So when you apply 100 hertz stimulation to other regions, nothing happens. But when you apply them to this region, orbitofrontal cortex, theta power goes down again, and mood, negative mood also goes down. Negative thoughts come down. So this is interesting. Depression is not a chemical imbalance. It looks more like an arrhythmia in the brain instead of the heart, in a specific circuit. An arrhythmia, which is of the activity stuck in a loop in alpha and theta power. And if you're willing to have surgery and have hundreds of electrodes implanted in your brain, we can help. But the real question is, do we need to do the surgery? Can we do this without surgery? Well, it's possible to put an rTMS coil over the orbitofrontal cortex, and we can do 1 hertz stimulation. Low frequency stimulation inhibits the activity of this region. So we decided to start trying this. We try rTMS over the right orbitofrontal. Which patients? Only patients who already tried conventional rTMS. No effect. For those patients, we move the coil. We try a second time, right orbitofrontal stimulation, 1 Hertz stimulation. The very first patient we tried, in her we had 2 kinds of rTMS, dorsolateral and dorsomedial. She failed 30 days of dorsolateral, failed 30 days of dorsomedial, refused ECT, so we tried this instead. Remission. And the scan showed the effect of this kind of rTMS is very different. Conventional rTMS strengthens activity of the dorsolateral prefrontal cortex. This suppressed the activity of the right orbitofrontal cortex. Completely different mechanism, but that mechanism achieved remission in this patient. We tried another 42 patients, and we got another 24% of them to remission and 30% to respond. This is important because every one of those patients already tried rTMS with no effect. So now we are only taking the non-responders. You move the stimulation to right orbitofrontal cortex, you get more remitters and more responders. So this seemed to work out well. All right. I'll ask one final question to conclude then. What I've shown you is that in the last 5 years, rTMS has gotten 10 times faster. Sessions are 3 minutes. Now I'm showing you that rTMS is evolving from 1 session per day to 2 or 3 or 5, maybe 10 sessions per day. And not only is the treatment now 4 or 5 days instead of 4 or 5 weeks, but the success rates possibly go up instead of down. The third thing is that not all depression patients have a problem in the standard conventional dorsolateral prefrontal cortex. Some patients have a problem in right orbitofrontal cortex. We can identify them. Even if we don't identify them, we can treat them. So this becomes a possibility to do personalized medicine. New plan for rTMS. And we have a grant to do this, but I'm not sure if we should do this. rTMS, before you do the treatment, everybody goes to the magnetic resonance imaging scanner, and then we look at the scan, and from the scan we decide you have either orbitofrontal or standard. But do we want to do that? Is personalized medicine always the highest impact strategy for illnesses which have very high prevalence? Can we do magnetic resonance imaging on 2% or 5% of the whole population? I don't know any country in the world that can afford to do this. Right? I also don't know if it's necessary. We love personalized medicine in psychiatry because it has shown success in some specialties of medicine very well. And there are some areas of medicine where personalized medicine is a good idea. If the intervention is very expensive and not very many of them, like deep brain stimulation, electrodes in the head, that's a good time to use personalized medicine because we only have a few stimulators. We should do everything we can to try to predict if the stimulator will help that patient. But for escitalopram, you could just give escitalopram. It would be much less expensive. So and likewise in cancer treatment, when you can only do 1 or 2 interventions, you need to personalize because you have to choose which medication to do. Right? But do you notice that for HIV, sorry, I don't know in Spanish, what is HIV in? VIH. Okay, VIH. There has been some progress in the last few years, but not because of personalized medicine, because of the opposite. Because 30 years ago, every medication for VIH was very expensive, lots of side effects, Some of them need to be 4 times a day with food, with refrigeration. If you go to some small village in Africa and you bring these medications, it's not possible to do all of this. And each one is $100,000 per year. No country could afford to do this. So you notice that nobody came and said, we will solve the problem with personalized medicine. Nobody said, we will use artificial intelligence to predict the virus, and then we will pick the one medication which is perfect for them. We never said that. We said that won't solve the problem either. What we need is the medications cannot be $100,000. They have to be $1,000. And they cannot be 4 times a day. They have to be 1 time per day. And they cannot need refrigeration. They need no refrigeration. They have to be very simple. And they have to be very reliable. We will not try to outsmart the problem. We try to outdumb the problem, if that makes sense. No, and there are some areas in medicine where this has been the better approach. So whatever your area of research in psychiatry, I urge you to think about which problem is the right one. For some problems in medicine, the approach of HIV, one medication, less expensive, is the correct one. For others, like in cancer, personalized medicine is the correct approach. So we have 2 strategies. For our depression patients, we could scan everybody with magnetic resonance imaging and use the scan to choose dorsolateral, orbitofrontal, dorsomedial rTMS. But one of my patients said, why do this? If the treatment is only 3 minutes, then give all 3 of them. Just do all of them at the same time. This becomes possible if the treatments are fast and inexpensive. So to conclude, our lab has decided that maybe we're not going to work on personalized medicine as much anymore. We think maybe the better impact is to continue to make rTMS less expensive, more convenient, and available to everyone in the world, and really simple. So how do we make rTMS $3 a day? Right now it's $400 a day. We got it down to $40 a day. I would like it to be $3 a day. Well, this is difficult. For the $400 per day, about $5 is for the machine. About $5 is for the coil. About $10 is for the technician. About $20 or $30 is for the hospital. And the rest is profit. So, how do we make rTMS $4? We have to fire everybody, including myself. I have to fire myself. To fire myself, the patient must do the treatments themselves, at home, not in the hospital. This is a huge advantage. If we can make rTMS safe at home, it's only $3 or $4 a day. And there's no driving, no problems with traffic, no parking. And if you live far away from a famous institute, it's okay. You only come once. You go away, you come back once in a while. All we have to do is make rTMS safe and simple at home. Right? And when I say safe and simple, it doesn't have to be perfect. It just has to be better than medication. Right now, we decided it's safe to take a patient who has thoughts of suicide and say, here is amitriptyline, 90 tablets, promise me only 1 per day. If you're having a crisis, promise me you won't take them all at once. I trust you. Right? rTMS only has to be safer than that, okay? So, we are developing ways to make a big stimulator which will cover the whole head. So you don't have to be very careful with the aim, you can just cover the whole brain. They already have these helmets. There are some rTMS stimulators that are helmets, you don't have to aim them. So that's pretty simple. This would be safer than for a patient who is a diabetic injecting their own insulin at home. What's the other risk with rTMS? 1 in 1,000 people, you do the stimulation, you have a seizure. So we don't want a seizure. But the seizure only comes with high frequency stimulation, 10 hertz, 20 hertz. We also have low frequency stimulation, 1 hertz. Low frequency stimulation is safe in seizures. In fact, low frequency stimulation in epilepsy patients reduces the frequency of the seizures by 50%. Also, if it's only 1 pulse per second, the machine can be smaller, less powerful, and less expensive to manufacture. So the big thing we are working on right now is to encourage the companies to build home rTMS devices, very simple ones, only do 1 hertz. But a lot of people respond well to 1 hertz. It works just as well as conventional stimulation. You can't do it in 3 minutes, you need 10 minutes, but that's okay, so 10 minutes. It's at home, it doesn't matter. And this is how we think we will get rTMS to be real progress. The single most important thing is access. Access for everybody. Affordable access for everybody. And so we think some of the science needs to focus on firing everybody and on making the machine very simple and proving that these machines work. And everybody can have rTMS at home for $3 a day. If it doesn't work, then you can come to the Institute. Then you can do the more extensive investigations, and then we will do personalized medicine. But before we do personalized medicine, we need something for everybody. I think that's really important. I think it is the only way that we will reduce the prevalence of depression in a meaningful way using brain stimulation. We're already doing as much as we can with medications. We're already doing a lot of what we can with therapy. To bring the number down, we need something else. I think brain stimulation, non-invasive brain stimulation, can do the trick if we make it simple enough for everybody and affordable enough for everybody. What I hope, my hope, is in 10 years, we will see the percentage of people with depression come down, just as for smallpox, just as for polio, because of new tools, better tools. So maybe in 10 years we'll come back and talk again. Thanks very much.